Hello, everyone. Welcome back to how to do an independent medical exam. These are short little videos to give you little tips and tricks if you're going to go to an IME or you just want to learn about IME. Observation guidelines by body parts. When observing an IME, you need to document both what the patient says and what they do. Watch for inconsistencies between the reported pain and their actual movements. You could look up something called Waddell's signs of malingering. A lot of times there's 5 signs that docs use to tell if a patient's faking. I've seen this many a times and I have documented it, and attorneys have been appreciative. General rules for every exam. Note how they walk into the room. I'll always at some point put like their gait was steady and balanced and not distressed, or their gait was slightly to the side or unbalanced gait. So I will address if a gait, especially if they have a cane, or a walker, if their gait is a little abnormal. That is a huge thing to document. Observe how they sit, stand, move when they think no one is watching. I even have a law firm that sends a general letter to people that will say the exam starts the moment you get out of your car, or even maybe when you get in your car at your house, because the defense knows where that plaintiff client is going on that day because they're the ones that set up the IME. So they're like, okay, Judy Jones is going to this IME on this date. We're going to have investigators, sneak around and watch her. So that is a big deal. I mean, because they can be walking in, into the building, no problem, and then we get called out of the waiting room, and then the limp starts. Hasn't happened too often. I don't think I ever really noticed it, but their defense wants to try that. And if they want to say they saw that and you have something different, well, then that's something plaintiff may like. Document whether movements are fluid or guarded. Yeah. What guarded, that means like they're very cautious, like flexion. They just go, a little bit. And they're afraid to do anything. Fluid, yeah. Sometimes I've seen people with back complaints have better lumbar flexion than I do. Doesn't mean that they weren't injured. It just means that IME, which is years later, their back is doing better. But that's just good things to document. Record exact times for activities like walking, sitting, or standing. If they'll have them walk in the hall, kind of try and time that. You can ballpark it. I do have a watch sometimes, or sometimes I'll just see the clock on the wall, or I'll pay attention to my phone. I will definitely put if they are standing for a long time. A lot of people, if they have a lot of cervical and lumbar problems, they can't stand for a long time. They're going to say, no, I have to sit down. Or if they're seated for a long time, I've been in those 90-minute neuro exams, they have to get up and move and walk around. And I know it all. Knee exam observations, the range of motion, internal rotation, external rotation, flexion, stuff like that. Any fluid, around the knee, and any pain on the touch for palpations. I already mentioned it. Note if the patient and limps entering the room. Watch how they sit down. If they cross their legs, that's a huge one. Another thing, and I actually, we're supposed to be independent in these things. So I'll just say this. One of the oldest tricks in the book that docs do for back issues is when they'll go through the history and they'll say, okay, let's do the exam. Remove your shoes, please. And I can't do it. I mean, I'm sitting in a chair, but they bend all the way forward for a good amount of time, untie their high top Converse, and then take them off. Doctor documents that that flexion was X amount of time and with no distress at that moment. Oh, time how long they can perform a straight leg raise. Yes, straight leg raises are huge. They'll do them twice, and that's something I don't want to call it a trick, but they will do straight leg raises seated and supine. Most docs will. And they'll always put it this way. They won't say, "Do you get any pain in your back when I lift your leg?" They'll grab the client's leg, lift it up, and say, "What happens when I do this?" And the patient, if they have clinical back issues, that hurts right in the lower part of my back. Sometimes, or sometimes they'll just say, "Oh no, I have a little pulling maybe at the bottom, but they not a lot of complaints." But then they'll put them supine and they'll do the same thing, and it's just like you just took a knife to them. They'll call that faking. That doesn't happen very often, but they'll always do it twice. And your attorney is going to want to know that. Document any difficulty with squatting. Yes. And sometimes instead of doing flexion and extension and lateral bends and rotation, they'll have them squat. And I usually will put the amount of time and if they had any distress and anxiety trying to perform the squat. So that's my little tips on this video. I'm going to be doing some more videos. Of course, I do have the ABCs of IMEs. If you want to dive into this deeper and learn from me specifically, I'm in New York State. I do about 30 of these a month, 20 to 30. In summertime, I get more. I mean, you would think summer would be less, but summer's more. Uh, right up here, Tim Kane at medicallegalconnection.com, or the link below is for the course. And I pretty much do everything in my power to help you. Have a great day and see you in the next video.